Okay, so today we're going to talk about long duration medical planning. And I say sort of because I realize that I'm not going to cover all of long duration medical planning. What I have here is kind of a potpourri of topics, things that you need to think about when you're thinking about long duration medical planning. And also just some of the issues that I'm interested in, and also some historical items, things that I've been involved with in the past that involved procedures that are relevant for the whole issue of doing surgery in space. So we'll talk about some of the things that have been done in the past because they're going to have some relevance for the future. We're not going to talk a lot about habitat design. We talked a little bit about that when we were talking about decompression sickness, but one of the key things, though, is what are you going to have is the atmosphere in your habitat. If you're going to be on the moon or if you're going to be on Mars, what is the atmosphere going to be? So we know from the other discussion the other day, if you raise the cabin pressure, so that it's like it is here on Earth, well, then you have to deal with the risk of decompression sickness every time you go on an EVA. So raise the cabin pressure, use a sea level pressure, and breathe out, nitrogen, oxygen mix rather than every time you go on EVA, you have to get rid of that nitrogen, then you load it back on again when you come in. So then the other thing is, well, you can lower the cabin pressure, but the lower the cabin pressure is, the higher percentage of that cabin atmosphere needs to be oxygen. So you need to keep increasing the level of the percentage of oxygen in the mix in order to provide enough oxygen for living. And then you start to get into the risk of fire and safety issues with the equipment that's in the within the habitat. So what the current proposal, just to cut right to the chase, the current proposal that's out there right now that NASA is working on is an 8.2 psi atmosphere. So we're at 14.7 here on Earth, and a spacesuit is about 4.2. So they're saying an 8.2 psi with a 35% oxygen mix is currently thought to provide that nice little Goldilocks balance between a pressure not being too high, but then the oxygen level not being too high either. So it's a slightly hypoxic mix, but that's what's currently proposed to have in the atmosphere in a habitat. And then the other thing I wanted to talk about was just something to keep in mind with immunological changes, because these clearly occur. If you look at there've been a lot of studies done looking at immunological changes that occur in space, particularly having to do with viral reactivation, which is a sign perhaps of immunological compromise. But it's important to keep in context here, because this also happens in Antarctica, and it happens at a lot of times when people are under psychological stress. So it's often difficult to ascertain what is the reason for immunological changes that might be seen related to space flight, because not everything that happens in space is necessarily related to weightlessness or being in a radiation field. So it's important to keep that in context. Also, in a distinction to a lot of the things we've talked about, like kidney stones or bone loss or balance changes. So far, there doesn't seem to be an increase in opportunistic infections or the development of cancer related to spaceflight that would suggest a major immunological compromise. So it's important to put those immunologic changes in context, and they obviously need a lot more study, because things are happening, but it's not really clear, are they related to weightlessness or something else? And what is their long-term clinical relevance? So that's something that's just a set of questions that are still out there for investigations in spaceflight. And then the other thing, is that I'm sorry, I said surgical space. Surgery in space is very interesting. It's a fascinating topic. What's the right kind of anesthesia? How do you restrain people? What kind of procedures should you have the ability to do? But it's always something to keep in mind that when you look at reasons why people get evacuated from submarines or from Antarctica, it's often for psychological reasons. People are taken out because of depression or anxiety, or they can't stand being in the environment anymore. So there haven't been a lot of reasons to do surgery in space, and there have been other expeditions like the Lewis and Clark expedition. I was back in the 1800s, had about 40 people. They lost one person, and that might have been due to appendicitis. So surgery might have been helpful there. On the other hand, they had a successful mission with not a lot of medical care. Same thing for the Endurance expedition down in Antarctica. Everybody made it back, despite being basically on their own in Antarctica for 2 years. So it's important, again, to keep this in context as well. The most common operations here on Earth are hernia repair, appendectomy, and cholecystectomy. And so clearly, hernia repair, if that's an issue, you want to have that taken care of before you go into space. Appendectomy has generated some controversy because there's some thought that maybe you should have a prophylactic appendectomy before you go on a long mission in space. And that has been done in the Australian Antarctic program, where they have people on a winter rover with not really a lot of capability to evacuate people or to do, abdominal surgery. So that is one approach, is to have a prophylactic appendectomy, although, these days it is possible often to treat appendicitis with antibiotics and watchful waiting. Cholecystectomy, clearly there, a key element is prevention. You want to make sure that people don't have pre-existing gallstones that might cause a problem later on in space. But then the kind of surgical things that are going to happen in space are going to be the kind of things that would happen on a work site, right? It's going to be trauma. It's going to be injuries to hands, things getting in people's eyes, broken bones, lacerations, that sort of thing. That is probably what people are going to be facing when they're on a habitat that, say, on the moon or Mars. There's probably not going to be a big call for elective intra-abdominal surgery. There may be a call for, having to deal with an acute trauma event, like on a battlefield. So it's that kind of emergency medicine, trauma medicine, that's probably the thing that you're going to have to prepare for the most in space or in a habitat. So far, there hasn't been a need for any surgical intervention in space. So I wanted to just talk a little bit about my experience, because a lot of times people ask, what has been done in space? Has there been surgery in space? Have people done different procedures in space? Have they used anesthesia in space? So I was been involved in 3 Space Lab missions, and the Space Lab Life Sciences 1 flight, which is in 1991. I was one of the investigators on that flight. And one of the experiments I was involved with on that mission had to do with putting catheter in. We had an indwelling catheter in between Space Lab Life Sciences 1 and Space Lab Life Sciences 2. We had 3 people who flew with indwelling catheters inserted through an arm vein and then advanced to just outside the right atrium. So that has been done in space, not just by us. It was also done by subsequently by a group from Denmark as well. So people have flown in space with indwelling catheters. For the Space Lab Life Sciences 2 flight, I was a alternate payload specialist. That means I didn't fly in that mission, but I did do all training for all the experiments. And that particular mission included a lot of animal research. So there were a lot of procedures that we trained for and did as part of that mission. And then the Neurolab mission in 1998 was the mission that I did fly on, had a lot of different procedures that we did that I'll show you some pictures about, that really involved some really fussy procedures and anesthesia and surgery and things that we did in space. So just to reiterate, the Space Lab program had dedicated life sciences missions. So there were various human and animal experiments, and a variety of different things were done. Experiments with medical restraint tables, IV pumps, etc. And there were also intensive animal dissection and surgical procedures on animals, not on people, obviously, but on animals. And I'll just show you some pictures of some of these things. This is Tammy Jernigan. I guess she's doing an ear exam on Sid Gutierrez, the pilot, who is testing out a medical restraint table. So this is one of the experiments to have a medical restraint table that you could use to restrain people while they're in weightlessness in order to do medical procedures. And so that's a common feature on the space station right now. They also have a medical restraint table that can be used for this sort of thing. There's been a long-standing interest in how to do CPR in space. And this is Brent Jett doing CPR or simulated CPR on John Blaha in the middeck of the shuttle, looking at different ways that you can do CPR. You know, the key challenge, of course, is restraining yourself so that when you're pushing, you're actually compressing the chest and not just pushing yourself off in another direction. So there's been a fair amount of work that's been done on doing CPR in space. This is an ISS medical kit from the early 2000s. And as you can see, it's got a restraint table that you can use for doing procedures. This thing over here is the defibrillator. So you have the ability to do, you know, advanced cardiac life support. There's some IV fluids in here, as well as a bunch of, you know, different IV starting equipment, some drugs. And then there was, you know, the ability to provide oxygen and a mask, you know, for ventilation in case of an emergency. So these kind of capabilities have existed on the space station. Of course, on something like a capsule flight, it's going to have to be even less because you don't have that much room to carry a lot of medical stuff. But what has been done in space? So the surgical procedures, at least that I'm familiar with, is tail vein cannulation. I don't know, those of you who worked with rats in a lab, you may have done this, which is basically putting an IV into the vein in the tail of a rat. And that's a very, can be a fussy procedure. Those are 25 gauge little IVs that go into the tail vein. And so those were done. Those were all part of the SLS-1 and SLS-2 mission. Time dissection of the temporal bone. So as part of research on looking at the inner ear and how it adapts to weightlessness, in order to do that experiment, the temporal bone had to be taken out and put into fixative within 2 minutes. So that was a very challenging thing in order to get that done quickly. So that was one procedure that's done. Timed laminectomy. This is an experiment that was looking at changes, adaptations in the spinal cord that are related to the changes in muscle that occurred in space. And in order to do this, it was important to remove the spinal cord, which involved taking out the posterior part of the vertebral bodies, and to do that as fast as possible. So that's also a procedure that's been done in space. Various dissection procedures for the rats. Perfusion fixation. Often I'll get asked, people will be wondering about taking various chemicals into space. So we had basically, fixatives that were used for fixing tissue like you would have in the lab. And we did perfusion fixation, which involved, pumping the preservative through the bloodstream in order to preserve all the tissue. So that's been done. And then also survival surgery. There was an experiment that was dealing with young rats and was looking at the soleus muscle, which is one of the anti-gravity muscles. And in order to do this experiment, it involved visualizing the soleus, which is a fairly small muscle, doing a little micro injection with a tracer, closing the wound, and then recovery. So that's all stuff that has been done in space as part of these different missions. How was that done? Well, one of the things that was used was what's called the general purpose workstation, and basically it's a glove box. So this is the workstation with the front open, and it had one person could be on one side, the other person could be at the front. And this was a table that was had corks, so you could attach things to it. Then there were different sharps containers, and then a variety of different kits that you could use that contained syringes, needles, instruments, all the things that you would need in order to do these kind of experimental procedures. That's what it looked like when we had everything all deployed. We had lots of different kits. So there were different vials that had, some had fixative in them, some not, that we used to preserve the tissues. We had gauze pads. These were kits that contained the instruments that we used. So there was a fair amount of preparation and planning to do these different dissections and procedures in space. It is my crewmates. In the back there is Rick Lenahan, who's a veterinarian. Dave Williams, who's a physician from Canada, and Jim Powelzik. And this is before the mission. We're in a mock-up in Building 36 down at Johnson Space Center. And this is a mock-up of the workstation. And we're working through one of the sets of experiments within the workstation. They have two people working at the same time and also wearing these surgical loops in order to provide some magnification, because you can't be right over what you're working on. You have to be sort of at an arm's length. And so that's the surgical loops allowed for that to take place. To prepare for all this work, we also did some weightlessness flights. We did some parabolic flights where we tested out the procedures, made sure that all our restraint procedures were in place in order that we could once we got on orbit, we'd be able to go through everything and get it done pretty smoothly. And then this gives you a little sense of what it looked like in flight. You can see we have two people, one in the front, one on the side. There are all the surgical instruments. All the surgical instruments had Velcro on them, and then we had these Velcro straps so you could attach them to the work table. And then you can see in the back here, we have these various syringes and then lots of other instruments and other things that are all tacked on with Velcro around the back. So it is certainly possible to do a lot of fairly involved medical procedures in space. And this is one of those one day in flight. You can tell it's in flight because you see the little this is floating here towards the back, our little loops. So we're wearing our surgical loops. This is one of those experiments that involve the perfusion and fixation. These are the pumps that we used to pump the fixatives. And then these are all the vials where the tissues went, and then there were syringes and the surgical tools. So that was just a little introduction to some of the things that we have done in flight. One thing we did after the mission was we did kind of get our opinions about how easy or hard was it to do these things. And so we asked 3 questions on a 5-point scale. Whether you strongly agreed or strongly disagree. And so one was dexterity was not changed in space compared to terrestrial experience. Fine motor was not changed. And then it was no more difficult to control instruments in spaceflight compared to my terrestrial experience. And I think what you can see is early in flight, there was a little bit of an adaptation that went on as we all kind of adapted ourselves to being weightless and got better at working with all the equipment and doing the little fussy procedures that we were working on. Whereas late in flight, I think we'd kind of gotten adapted to weightlessness and it all seemed a lot easier. And although controlling instruments was more difficult because you always had to make sure that any instrument that you use, you couldn't just put it down. You had to make sure it was secured down so that it wouldn't float away and go elsewhere. If you're interested in more information on what this was, after the mission, I did edit a book with Jerry Homick, who was our mission scientist. And so this book has, all the results from the mission and also describes some of the surgical things that we did. So basically, just to summarize, surgical techniques have been successfully demonstrated in rats during spaceflight, and those have included general anesthesia, wound closure, wound healing, hemostasis, control of surgical fluids, restraining the operator, which is very important, and control of surgical instruments. So a lot has been done, and I think it's important to keep that in mind as we move forward, that we not forget what's already been done. And delicate surgical procedures were performed successfully. A lot of these procedures were fairly fussy little microsurgical procedures. And we also did the first survival surgery with the rats. And then ACLS procedures and protocols have been worked out on previous flights. that were prompted early on in the shuttle program by, the need to have that in case there was an issue that came up where, you needed to be able to resuscitate someone. So I thought I'd just keep it short and go through some of the things that I've been involved in and the relevance that might have to the future. And I'd be happy to take questions, or we can move on to the other presentation.
Hey, I had a quick question. Gufran Said here. I had a question about, so it looked like you had supplies on the side, but then wouldn't sort of basically, as soon as you did some experiment, wouldn't like everything just get contaminated? Or was there some kind of like directional airflow or something to sort of stop all of the supplies that you're not using getting contaminated?
Okay, I'm sorry. Well, so the question was about things going all over the place?
Yeah, in the glove box, because it sort of looked like, you'd have your the sort of, the subject that you're working on, you'd have your instruments, but then there's like the syringes, and then there's other things. Would you basically have to change that all out for like each new experiment? Or...
Yeah, so all that stuff was stowed as kits. And so when we would, let's say we were going to do the perfusion fixation experiment, we'd open up the workstation, we deploy all the kits, we get it set up, then we close the door, get our hands in, and then get going on the activity. And then for fluids, it turns out that most of the fluids will form a ball. So they would form a ball, you could just wick them down into into gauze or whatever. So it wasn't like there was fluid flying all over the place. It was actually fairly easy to keep those fluids contained.
Thanks. Oh, I posted a link to that Neuralab thing. I managed to find it.
Oh, great. Thanks.
Matt, it looks like you have a question too. Go for it.
Okay. So we have a hand up here.
Yes, thank you, Dr. Buckey. I just had a question. I know you were talking about more of the trauma, like there's going to be like a less likelihood of some of the most common operations to happen on Earth to be affected in spaceflight. You talked about how there's more going to be like workplace trauma injuries while in space. I'm not sure if you mentioned this early on. I was just having some trouble with the link, but have there been any examples of more of that trauma-based situations that have happened on or during spaceflight, and like how have the astronauts or the ground kind of adapted to that?
That is a great question. The biggest thing I think is people getting things in their eyes. And I don't have a good example of that. As far as anybody like getting a laceration or having a traumatic amputation or anything, I'm not aware of anything like that. Things that have been very common are urinary retention. I think I mentioned that in the earlier on in the motion sickness thing, but a lot of the urinary retention that has occurred has been associated with people getting IM promethazine. So you get IM promethazine for motion sickness, it works great, and then you can't pee. And so there've been several cases of that requiring catheterization in space. So that's definitely been something that's happened.
Yeah, I actually just remembered something that I heard about Chris Hadfield and how he kind of developed like a space blindness when he was in one of his EVAs after having exposure to, I think, like a gas leak in his spacesuit. So that kind of like brought up again one of like the things that may have happened during space flight.
Right. Oh, yeah. And I forgot about that. Just like in the Mir program with the fire, that was another big, toxin exposure. Yeah.
Thank you.
Shoulder, hand, fingernail injuries from the spacesuit. That definitely happens.
All right. If there's no other questions, we can go ahead and move on to Jerry's presentation. Jerry, I believe you should already be able to screen share, but let me know if you have any trouble.
All right. If I do, it's probably because my computer is acting a little funny. I think because it was dead and then I started up as I jumped on this call. So if you guys have any issues seeing my screen after I share it, or if anything weird happens, just
Great. Well, thanks for doing this. You always have some great comments every week, so this is good.
hopefully you can answer some of my own questions that I've created for myself in the process of trying to go about this. So I'm sure I will have some questions for you after my own presentation because I encountered a lot of things, and I wonder if you feel like there is much of an issue as the way sometimes they're described. Like, for example, we can talk about it at the end, but basically a lot of the papers, I read a bunch of papers and kind of did more of like a synthesis of a few topics that interest me, because it is such a vast topic of, how to care for people in space and plan for it. So I kind of looked at a lot of the major concerns, and one of them that came up was the issue of open abdominal surgery being potentially, contaminating or just like difficult. And it was interesting to hear your anecdote just now about how from your experience, like the fluids were fairly easy to contain. That was not something that I thought was reflected in the literature that I found, but I believe you, obviously, for sure. That's really interesting. Well, so anyway, so I'll get started on this. And so basically, I would say kind of synthesize all these ideas under the umbrella of emergencies that will pop up in space, because obviously we don't have time to plan for non-emergent, medicine that we have so many emergency contingencies to think about that's really where it's mostly focused, right? Which could include surgery as well. So I will talk a little bit about that as well. And so I should be in presenter mode now. Can people see this?
Yeah, it looks great.
Okay, great. So full disclosure, I am a second year medical student. And so, a lot of these terms and pieces of equipment that I'm going to mention are new to me as well. So feel free to, raise your hand, jump in and interrupt. I used to be a teacher, but I'm out of practice with monitoring the chat. So if somebody has a question or something, just pause me or yell at me or whatever. So here we go. So just some background, stuff that I was teaching myself essentially is that basically the current healthcare system, obviously, as you know, is more designed around in the space station is more designed around evacuation. Some numbers that I found that I thought made it kind of relatable for me were that supposedly you could evacuate with the Soyuz capsules, and there's apparently 2 of them. And apparently you can undock within about 3 minutes and get to Earth within about 3 to 4 hours. Now, what sorts of like traumatic situations would that be helpful in? And how traumatic is the process of doing an emergency evacuation to Earth? I don't know the exact details, so I'd be curious to hear from Dr. Buckey at the end about that. So that's one of the questions I have already. But so obviously this International Space Station is, not considered deep space. Most of the medical procedures surrounding it are, you can evacuate fairly easily. So the current CMO, Chief Medical Officer on the ISS at any given time, does not need to have a medical background. They have about 60 hours of medical training. And, that's basically not going to cut it for deep space missions because you're not going to have that evacuation option. So the idea is that, if a return to Earth from somewhere like Mars is going to take around 9 months, that is not an option in emergency. You really need to have that care delivered at the point of injury or, nearby. So a slightly less extreme scenario is, on the moon, you've got about a 6 to 7 day return. And so, if you have a serious emergency, that's evacuation there is also not an option. So one of the things that I just kept coming across over and over again is the lunar regolith considerations. And for those of us who are like me, sort of new to space medicine and thinking about these things, the regolith is basically, in my understanding, a fancy term we use to describe the substance on the surface of the moon that has a really interesting property of being a very fine powder that is very coarse crystalline, very small particles that get charged and they become lofted into the air, into the atmosphere, I should say. Whatever tiny atmosphere there is on the moon is essentially composed of this lunar dust, which is the smallest bits of this regolith. And so I don't know if I can point with my mouse right here, but basically, one of the things that's potentially handy about it is that it has a sort of temperature and radiation protection ability, so to speak. So, one of the things that you can do is take temperatures on the surface of the moon versus below the surface of the moon. And these temperature variations that are drastic on the very surface, many hundreds of Fahrenheit flux, is totally negligible, just a few, 100 centimeters below. So, that's an advantage if you can exploit that in terms of, reducing energy costs of, potentially building long-term structures that would be, long-term lunar habitats. Also, it's protective against radiation. So for those two reasons, a lot of the literature that I found was suggesting that, any sort of efforts to establish a long-term base on the moon would end up utilizing the lunar regolith, either, putting it into some sort of, bags, almost like sandbags, and, covering certain structures of it with like that, possibly even, mixing it with some sort of liquid, possibly water, making building materials out of it, that sort of thing. So it's a handy material, but it's a toxic material. This photoelectric charge that it gets from being bombarded by, I guess, solar radiation constantly, and it's very fine particles from millions of years of being bombarded with meteoroids. And so, there's this combination of tiny particles that are charged and kind of levitating and adhering to things. I'm picturing like static electricity, but asbestos 2.0, clinging to all of your materials whenever you leave and you do an EVA. So some of the descriptions I found from the Apollo mission, or at least this quote from this paper, was, that the astronauts found that basically it was clinging to everything. It choked even the vacuum cleaners that were designed to clean the spacesuits and craft of the dust. So this reduced gravity and all these fine particles and this sort of charged electric quality of the particles just makes them really difficult to clean out of the air. And so it's an important health consideration of any sort of airlocks or spacesuits designed to prevent the inhalation of this dust. And without going into too much detail, it's kind of, something that can irritate the lungs and cause like interstitial lung disease. And it's obviously not good stuff to be breathing in all the time. So like that's sort of core to creating any sort of healthy medical facility on the moon, or any sort of healthy anything facility, would be to really minimize the amount of that lunar dust that's getting into living spaces. Another thing that's interesting to consider is the telehealth implications of the distances. So, communications to the moon are about 1 minute delayed, maybe 1 to 2 minutes from different sources I've read. And the return trip, like we mentioned, is about a week. So evacuation is not an option, but telehealth relays would be relatively effective. If you had, for example, a lot of the literature I've read suggests, if you're going to have a long-term base on the moon, you would want a medical doctor that was experienced in remote medicine, but obviously, the emergency medicine type doctor, they consult experts, right, when things happen. And so to be able to make those consults, or if there's a surgery that needs to be done, be able to communicate with Earth with somebody that has expertise in a specific field is part of emergency medicine, right? And so to be able to do that with about a 1 or 2 minutes delay is something that is fairly reasonable. However, if you're on these deeper space missions like to Mars, it's interesting that the distance between the closer orbit, if you're in a closer aspect of Mars's orbit to Earth versus the distance, the further aspect of the orbit, that changes the delay from anywhere between 4 to 24 minutes, and that's in one direction. So you're looking at about 8 to 50 minutes to have a question and response conversation. And obviously the quality of communications can get distorted as well. So instead of having some sort of, decent quality video feed or something, you're probably looking at written questions that get responded to through some sort of, like email-like interface. So the idea of doing any sort of live guided operations become a lot less feasible. So just thinking about, are there even considerations for the types of procedures that, you could do with a 4-minute delay if you needed some feedback from an expert surgeon on Earth versus or I guess it'd be an 8-minute delay for like a question and response versus almost an hour-long delay. Even just being in different portions of the Mars orbit would really change the type of healthcare that you could deliver in terms of telemedicine. And so that's why this phrase telementoring is something that was coming up a lot for me, was this idea that, we think of telehealth as something that is fairly interactive, right? That's how we experience telehealth, but this might be something a lot more delayed, a lot less interactive potentially, depending on the distance. And it might be more like a coach that you can, like a pen pal. So depending on the distance, those are just very different types of telehealth that you might be experiencing. So related to that, I kind of touched on this already. So because of those situations, the idea is you would really want to have one crew member for really like a deep space mission, either to the moon or Mars, that's broadly trained physician, experienced in remote medicine, supported by onboard health informatics, which is honestly to be expected, right? We modern physicians usually have health informatics at our fingertips. But the idea is that we might also be able to build in some AI for assistance. I mean, these are expensive missions. So the idea that you might be able to build in some medical AI for future missions that could help to kind of diagnostically run through some algorithms or run the right tests when needed is an interesting concept. These telementoring experiments have been conducted in the NEMO missions, which I'm sure Dr. Buckey knows a bit more about than I do, but so there's been a few missions hosted in the Aquarius lab in Florida, the undersea lab there. It's the only undersea research station, at least that's currently operational. And they've done a number of experiments kind of testing out different surgical training skills with telementoring. Basically, people with minimal amounts of surgical training being coached through different types of surgeries. And they've even mimicked the 3-second delay that you would have on the moon. So the 7th experiment, or the 7th NEMO, which is, I guess, a subset of these Aquarius missions, they instituted that sort of 3-second delay to mimic that Earth-Moon communications. And they found that it was, teleoperated surgery would be potentially effective, and telementoring in particular is this idea, that you're coaching people through surgeries relatively live. The 3-second delay is not something that prohibits that. Another interesting thing that I found is the floating blood bank concept. So this is kind of based on another concept that we use on Earth called the walking blood banks. And the idea is that storage of blood doesn't last that long. I think it was around 30 days. I don't know if I included on this slide. And sorry for these disgusting looking slides. I was a little bit rushed today. Some things got planned against my will that I had to go to. So a little bit messy, but to summarize this for you, basically, some teams have looked at the types of transfusions that, if you had these hemorrhagic shock situations or, trauma with a bleed in a remote location, how would you transfuse blood? And we've never actually done that, to my knowledge, like a human blood transfusion in space, or even like IV fluids, although we do have the equipment for IV fluids in the space.
We have done the IV fluids.
Oh, you have done the IV
So on
fluids?
the D2 mission, one of the experiments involved an IV saline infusion.
Oh, actually, that's interesting because, sorry, my lights are shutting off on me. What I found was, so I misspoke. I think what I found was that there's never been an event, which I guess would have been an actual health.
Would you require it? Okay, yeah, okay.
But yeah, that is interesting. So you have used the IV fluids system with the human. I'm curious to hear what that was like, because what I found from this was, without going too much into the blood bank thing, obviously you need special equipment because there's no gravity, right? So one of the interesting considerations is the usual gravitational forces are not there for you. So you need to pump the fluid, correct?
Yeah, we had a bag that compressed we had just like a blood pressure cuff type thing that compressed the bag, and that caused the IV fluid to flow.
Okay, yeah. And another thing that was interesting that I don't think I put in here, but It was more about this idea that certain fluids in the IV that normally would just separate gas from liquid, have a nice meniscus or whatever on Earth. You might have this kind of like turbid, bubbly fluid. I don't know if you experienced that at all with your IV infusions.
Bubbles. Yeah. So yeah, that's you can put a filter in the line.
Yeah. So there was this discussion of filters in the line. So like little things to think about that I just thought were these little things crop up everywhere, including like the CPR. So this floating blood bank is something you might have heard of. I thought it was an interesting concept. So the idea is, this is used in basically in remote medical settings, like in military settings. People with compatible blood groups can essentially donate blood, which gets almost, immediately infused into the recipient in a situation of trauma. And so thinking about this as a way around, the short shelf life of most whole fresh blood is usually, I think, a little over a month. And so the idea, if you're going for 9 months or more, in these long missions, you would probably want to be able to have a system where you'd have people with compatible blood types that were there. And they kind of brainstorm a few options. One is having a couple different O-type donors that could serve as donors for everyone and each other. So kind of the rule of two here, I would say, like the buddy system is interesting there. And then, the other thing you could do is you just have pairs of people that have compatible blood types or groups. So 2 or more of any given, blood type, and they are able to donate to each other. And how much blood can you do? Well, in the military, it's been proven they can do about 2 units of blood. Normally, when you donate, they won't take more than 1 liter. And so I think in the military, they've proven that, healthy, young, active duty soldiers can donate up to 2 units in this style of donation fairly well. And there have been, it's been kind of controversial, but there was a fair amount of evidence that I was finding suggesting that this is a fairly safe method. And the idea is that, you would activate this protocol if you needed it. You'd have everybody pre-screened for infectious diseases, and potential mismatch would not be an issue. You double check that you had the blood types right. And you just need a little bit of additional equipment. So I think I have here, it's just another 370 grams of equipment to be able to make this type of transfusion compared to what's already on the ISS. So yeah, that's my understanding, is that it would not be a lot of equipment to create this sort of floating blood bank, just an interesting sort of logistical consideration.
Cool.
So this is a couple of interesting tidbits. So basically the fluid requirements are complicated by the microgravity situation. If you have just simple, hypovolemia and you're trying to figure out how much, fluid alone, just stepping away from blood for a minute. If you're going to evacuate that patient to Earth, right? If they have like a slight microgravity induced hypovolemia, you're going to give this person fluids. Now on Earth, gravity is going to come back. They're going to need additional fluid, right? But if that person is treated entirely in space, in the microgravity, they would require a little bit less fluid. And also they would probably require less if they were entirely treated on Earth with that same fluid hypovolemia. So it's just an interesting thing to think about, the way in which gravity may or may not enter the equation at some point in a resuscitation has implications for how much fluid should be given. So the standard protocols around these things and blood pressure potentially need to be modified with future experiments in microgravity. But obviously we don't want people going into shock on the surface of the moon, but it's tricky to know how these things will actually pan out until the experiments are done. So perhaps animal studies, et cetera, surrounding this could be beneficial. And maybe some people have even explored that. Another thing that's interesting is with head injuries, fluids should be cautiously given because people may already have intracranial pressures that are elevated. So, something to think about as well. And that last sentence there is a thought from the previous slide that I didn't have time to switch out. Sorry about that.
And there's just one thing I hope we all, is that intracranial pressure is probably not elevated above supine levels in space. So
Oh,
I
and
know that shows up a lot, but it's been measured in parabolic flight, and it's certainly higher than it is standing, but it's not higher than supine levels.
okay. All right. I was under, yeah, I guess I got thrown off. I found an ophthalmological paper talking about how that was the likely cause of.
Yeah, I know it's one of those enduring things out there. So yeah, so I don't know if, and then I guess the other thing is that it's just for hypovolemia. The only thing I would say is that you are hypovolemic compared to what you were before you launched, but as far as you've adapted well to space flight, you know, so your body doesn't perceive you as being hypovolemic.
Right.
Yeah.
I guess I just mean, well, why did I have this in here? I had this in here because this was one of the emergency medicine papers I was reading that was suggesting that you would just have to perhaps alter the types of protocols you would use, be considering these types of things, like would the fluids that you give for a patient with that was truly hypovolemic, or, you know, having a hemorrhage, if they were also being evacuated to Earth, would you need to give additional fluids? Perhaps, I think was the implication, maybe.
Mhm.
I don't know. So maybe they're overthinking.
I interpreted that as just your absolute fluid volume was less. So it's kind of physiologically appropriate for microgravity, but just the absolute amount is less. So if you lost the same volume as in a gravity field, that it might be more significant. Is that maybe what you were getting at?
Yes, I think that was also something that was discussed, like perhaps your tolerance for hemorrhage would be lower. This particular sentence that I, you know, kind of took out of there, you know, they may have just been overthinking things or creating problems where there aren't, but I just thought it was an interesting consideration that perhaps in the acute setting of some sort of hemorrhage or hypovolemia, the fluid or blood that you would give, yeah, maybe the more I think about it, I agree with you guys. It doesn't seem to be such an issue. Well, regardless, I'll continue on. And I was expecting to have some corrections from the experts, so thank you. So here was an interesting thing that I found, the amifostine for SPE, so the solar particle events. We talked about radiation exposure. This group basically identified 15 different pharmacological treatments that can be given for, you know, radiation poisoning. And they ran some experiments that suggest that amifostine, I don't know if I'm pronouncing that correctly, which is already FDA approved for radiation poisoning, but it's basically scavenging free radicals is the general mechanism, is promising against radiation exposure. Not all the time, you know, you're not going to be taking these things because they have some potential toxicity as well. But the idea is that if there was, you know, a solar particle event that was forecasted, ideally this group suggested taking it 30 minutes prior to exposure. Now, I thought to myself, I don't know if we can forecast these solar particle events well enough to give people 30 minutes warning, and then, you know, dose them with amifostine. So I did a little research on that, and it seems like the forecasting is, you guys could probably speak better to this than I could, but it seems like the severity of the solar particle event, if it's a milder event, they're very poorly forecasted, is my understanding. And as the events get more extreme, the forecasting gets a little better. But I don't know how reliably you could ever give somebody 30 minutes of exposure or 30 minutes warning. And so then the question becomes, and I did not have time to look into this, you know, is this still effective if you're giving it, let's say 10, 20 minutes, you know, 10 minutes, 5 minutes, or even, you know, within the same time frame as the solar particle event. So if anybody has any thoughts on that, I'd be curious to hear.
Yep, I don't know.
Yeah, so
I mean, I just know it needs to be given beforehand, but what benefit you get by giving it afterwards, I don't. I'm not sure.
I think on a Mars mission, sort of theoretically for a big SPE, you might be able to benefit from the fact that the sort of the fastest particle, basically the light, essentially the light and the sort of the particles are slower than light speed, right? And so sort of over kind of a distance sort of, from the sun to the earth and sort of onwards, at Earth, for example, you'll see the sort of massive solar event, maybe like, I don't know, maybe 30 minutes, I'm just guessing, but like, it's that order of magnitude before the actual particle, the major sort of maximum density of particles arrive. And so, for example, like, if you were on a Mars mission, that's not gonna help you. But for example, if straight away, like the Earth stations sort of transmit that this is coming, you might get some amount of warning, which would obviously be like the most when you're out around the Mars orbit and sort of nothing when you've just left Earth orbit.
Yeah. Yeah, that would make sense. It's interesting to me. I found a paper that suggests that for some of the lower level solar particle events, the forecasting models are a lot less accurate. And, and there were some false alarms as well as some undetected, where there wasn't warning given. And so, yeah, it's an interesting thing. Is this actually practical? Possibly. I'd like to learn a little more about that. Well, anyway, so moving on, one of the things I just found is kind of a interesting thing. This Virtual Incision Corporation has this Mira robot, which is like a laparoscopic surgery robot. It's like a miniaturized robotic surgery device, because if you've seen like the Da Vinci robots that we use like here at DH or in other hospitals, they're massive, and the consoles that the surgeons sit at are quite large, and the structure of the robotic arms themselves is quite large and heavy, and it's all just additional space that would be rarely used, hopefully not used at all, and hopefully there's no medical events that would require a robotic surgery, but it might be nice to have. And if the minimally invasive approach in the laparoscopic surgery, which is often preferred regardless, but seemingly more so preferred in space due to, at least some papers suggested, issues of contamination or blood, or like, for example, opening the abdomen and, because there's no gravity containing like the small bowel, that, these types of things are kind of more likely to kind of come apart or just be a little bit more, I don't know, just messy, I guess, was the kind of the description of the potential impact of doing like an open abdominal surgery versus a laparoscopic surgery. So a lot of what I saw was talking about how, laparoscopic surgery or robotic surgery would be preferred. And this particular company just seems to have made a really nice, I haven't used it, but it's pending FDA approval. They've done a right hemicolectomy, and they're planning on I think they've got a contract of some sort with NASA to test this device in space in the International Space Station, I believe. In the next, few years. I think I said I saw 2024, so that'll be interesting, and I can try to show a little video of that if I have time at the end. And the other thing that I found was also, as Dr. Buckey mentioned, cardiac arrest protocols are more or less the same and acceptable as advanced cardiac life support protocols we use here on Earth, with interesting aspect that you need to modify the way in which you give basic things like chest compressions. So this one paper compared a few different types of procedures and found that the handstand method, it sounds crazy, but this is supposedly one of the more effective methods of giving chest compressions, because as you can imagine, you really need to find new ways of delivering that same amount of pressure that would normally be assisted by gravity on Earth. So the rest of this is sort of miscellaneous things that I thought were interesting to consider. But first, I would want to show you a couple of these pictures that are, so the first one is that comparison of different, I'm glitching here. Can you guys still see me?
Yeah.
Yeah, well, for some reason, I can't click the second tab in my, oh, that's a bummer. I wanted to show you guys the different, basically the handstand method that this group found to be more effective is you need to have your feet on the opposite side of a wall, standing basically 100% extended, using your hands to do compressions over your head while your feet are on a wall opposite from you. So hard to arrange this scenario in an emergent situation, but this was found to be more compressive, to deliver more compressive force. And they've tested this in microgravity. Another maneuver that I'm really frustrated that my computer's not letting me click around now. I've got some weird frozen thing going on. The other thing they found was there's a procedure where you can drape your knees around somebody's shoulder and around their lower back, so that you've kind of like, you're straddling the patient, but you have your knees kind of like one around shoulder and the other around the lower back on the other side, so that you have essentially something that you can push against, which is the force of your own legs holding the patient against you to try to deliver those same chest compressions. So all sorts of interesting little things to consider. And the list just goes on and on. And yeah, so I found it very hard to try to rein in my curiosity here as I was trying to learn about all these different aspects. So there were some other minor things that, such as like lyophilized blood products, which my understanding is that they have much longer shelf life, but we haven't figured out how to do this with like actual red blood cells yet, I don't think. And somebody correct me if I'm wrong about that. And then hemoglobin-based oxygen carriers was something that people also suggested for blood transfusion alternatives as well. And I think those have been tested though with, mixed results and are not commonly used on Earth. It's more of an experimental technology. And that is also something that is a new idea to me. So I'm no expert on that, but I'm finding that the alternatives for blood products that might be used on these long space missions is an area of ongoing research. So that's really all I have. And if you guys have any questions for me, I hope I can answer them. And yeah, thank you for giving me the opportunity to speak today.
I was actually surprised that I think one of those hemoglobin-based oxygen carriers, like Hemopure, says it's not FDA approved, but there is sort of like compassionate authorization. So if people have like religious or other objections, they can actually use it. So you can use it sort of in an elective procedure for someone who sort of fits into that category. I suspect at some point you might get patients who just have like so many antibodies that like you might have to use something like that as an alternative, but that's usually going to be like pretty a specific group of patients that get a lot of transfusions over their lives and build up their antibody sort of portfolio, as it were.
Yeah, I did not know that. So I'm learning more right now. Thank you for telling me that. I did not know that was an option.
Can I just share a couple pictures real quick?
Yeah.
So these are some pictures of what the lunar dust looks like. So that's who's the character in the Peanuts cartoons, like Pigpen, right? That's who it was. But that's what it looks like with the dust around people.
Oh, wow.
And that's all the dust adhering to the suit. You can just see that it's just dust all over the place. And that's Gene Cernan back in the Apollo lander, it's covered with dust. So indeed, yes, the dust does get all over the place.
I see
Yeah.
a hand up, someone. Is that Skylar Link Schuler? Maybe that's an accidental hand.
Yeah,
Well,
I'm muted.
So I was just going to say, if anybody has any questions for me, I may or may not know the answer, but I can always redirect it to Dr. Buckey and those who do. So feel free, if any of those things incited any curiosity, to just ask away.
Hi, my name is Molly, and I'm a master's student and I study chemistry. And I saw that you were listing some of the different, the composition of the dust. And I saw people were talking about maybe trying to simulate a similar dust. Do you know what they're doing? They know the composition of the dust, if there's anything that they're trying to do with that?
Yeah, so I know one thing. which is that there's, I think it's the San Francisco Valley in Nevada, or San Francisco crater. There's a crater in southern United States somewhere called the San Francisco, or it's very similar to volcanic ash. And so there's a specific ash or volcanic material that is in this region, the San Francisco Valley or something, that so it's this substitute is called SF whatever, because there's not a whole lot of lunar samples that have actually been taken back, although some groups have studied and pulverized lunar regolith and to create dust that is a similar quality. But so there are substitutes and people have studied them, and I don't know exactly what it's not the exact same thing, but there are a few different I guess analogs that people use on Earth, and one of them is a naturally occurring substance from the southwestern United States, which is interesting. That's all I can say about that. But there are a few different substitutes that people are looking at and experimenting with regularly.
Thank you.
All right, looks like there's
Well,
a
thanks. I
question
think
in the chat.
I'm going through the chat, make sure if there are any questions directed, I think I got them.
I think there's
Right.
one more question. We can wrap up the session with this last question, but it's what's the source of the projected 1 minute delay to communication with the moon? Is that entirely signal processing based?
The source of the projected 1 minute delay communication to the moon. I think that's just signal. I assumed it was just entirely distance and signal processing based. I don't know if that is something that would improve with different satellite communication options. My understanding is that it's sort of a fundamental limitation, but I could be wrong.
Oh, okay, Charlie Link said comms in 2.6 seconds. Yeah, that sounds about right. Right, light speed. So yeah, that's right. Okay. Because you're just limited by the speed of light.
Yeah,
It's
I'm
not
sorry.
just a
If
good idea,
I
it's
put
the
1
law.
minute,
Yeah.
I'm sorry. That is my mistake. It should be 1 second either way for 2 or 3 seconds.
Round trip.
That's what I should have. And if I have anything else, it's either referring to the experiments that were conducted in the Aqua Lab or the Aquarius Lab, in which case they might have increased it just to be able to experiment with a longer lag. But I think it should have been 2 or 3 seconds if it was replicating the moon communications. So sorry about that. My computer's acting crazy right now. I've been trying to put this together at the last minute, and I have bizarre issues.
So, so I got a chance to go to JSC in April for the space medicine internship, which you should definitely all apply for when you can. And remember, you can still do it as a resident or an attending. So your chance isn't over once you graduate if it won't fit into your med school time you have left. So actually, like the project I was working on was to do with light speed delay and effect on team and task performance, sort of as we go to the moon and then onto Mars. So yeah, there's a lot of studies looking at kind of different levels. For the moon, obviously, like it's never going to be more than 6, right? For Mars, what's interesting is that there's 2 issues. One is the distance, but then the other is the conjunction, is like the angle. So there comes a time where if Mars is on the other side of the sun, unless we have some kind of relay satellite, it's basically there is no communication, right? Sort of possibly for up to 2 weeks. So that's but yeah, obviously, but in sort of Earth Moon system, it's just going to be the 6 seconds round trip.
Thank you.
All right. I do want to respect everyone's time. So
Yeah,
thank you, Jerry,
thanks.
for that.